Without any further ado, we will start first session of the day. We now call upon our chairpersons, Dr. Kishore Kumar Ubrangla, Professor, Department of Geriatric Medicine, Enapoya Medical College, with special interest in internal medicine, geriatric medicine, Dr. Arun S., Associate Professor, Department of General Medicine, KMC Mangalore. Sir has special interest with respect to diabetes, metabolic diseases, medical education, and infectious diseases. Dr. Pawan, Associate Professor, Department of General Medicine, KMC Mangalore, special interest in infectious diseases and nephrology. We request our chairpersons to grace the stage and chair the session.
Each and everyone, we are starting batting by Dr. Rajeev Kasliwal, and we are opening the sessions with all very important topics in the field of liver disease and triglycerides management and things one more thing is there, one more, obesity management. So these are all the prevailing important topics of the day, and we are glad to invite Dr. Rajeev to opening the meeting.
Thank you, chairpersons, for your kind introduction, and at the outset, let me thank Dr. Ganesh for inviting me. I'm coming to Mangalore first time. So today, as you just highlighted, we are going to talk about this important topic, which was there for even of a quarter a century or so with a different name, but however was not considered that significant. And nowadays, and in fact, in last 5 years or so, it started. This entity has started making waves in diabetic care or so. So these are just these guidelines which has come up in last 5 years, including ASL, EASL, INSAL, then global consensus statements and also, and that just highlights the paradigm shift that has happened in MASLD and the emphasis on diagnosing it early and treating it early. And that this slide just highlight those changes that has happened in last 5 years or so. The whole classification of has changed. Initially, we used to call it NAFLD. Now we call it as a SLD or MASLD. Now this category or this classification changes took place in 2023 to make the diagnosis more inclusive rather than exclusive. If we can remember, the NAFLD used to be a diagnosis of exclusion. So when there is no risk factors for fatty liver, then you used to label it as NAFLD. Now it has become more inclusive rather than exclusive. And second, it has taken out those two terms which used to create a stigma of like non-alcohol. So alcohol word and the fat word has been taken out from the nomenclature. So now we have 5 categories of disorders. One is MASLD, second one is MAT-ALD, third one is ALD, then fourth is SLD, which is further divided into 2. One is steatotic liver disease due to some rarer causes, and then cryptogenic steatotic liver disease. Now, what this classification actually emphasizes is the real world problem, because there may be an overlap of risk factors in our general population. A diabetic patient or a metabolic obese patient can also be alcoholic also. So where do we put him in terms of risk classification? The alcohol may not be too much, but it's kind of a social gathering, kind of a drinking. So there are patients which comes in between those. So that's why we have this newer entity, what we called as is MAT-ALD, where the alcohol consumption is below the limit which is responsible for the ALD, that is less than 50 grams per day in female and less than 60 grams in a female. Even for MASLD, some degree of alcohol consumption is included, like up to 20 grams in a woman and 30 grams in a man. So that, because that much amount is not known to cause the liver damage. So if there is a liver problem, then it is because of the metabolic factor rather than because of the alcohol. So just highlight that there is an overlap of risk factors in day-to-day life. Now, MASLD is a silent disease. It's asymptomatic most of the time. Very rarely some patients can present with discomfort in right upper quadrant, maybe because of the enlargement of the liver and stretching of the capsule. Otherwise, the main mode of diagnosis is actually incidental. where they are being picked up during some kind of routine evaluation, whether we take it statins monitoring or just a routine health checkups, annual checkups for insurance and so on. It may be diagnosed based on the blood-based tests like OTPTs are increased, or maybe just ultrasound which is showing a bright echogenic liver. So that is the main mode of treatment. Now, once we diagnose, MASLD, we need to understand certain terms before we need to familiarize what to do or what not to do. So, these two things I want to just highlight, because the MAFLD prevalence, as we know from all our experiences, that it's a humongous. You cannot treat everyone, and probably not everyone requires treatment also. So where do we should put our energy? Whom should we focus upon? That is what we wanted to know. So these two category of patients, so patients what we called as not only MAFLD, not only MASH, that is fatty liver disease with inflammation, but out of that group also, basket also, we want to focus among MASH at risk patients. So these are the patients who are ultimately going to progress to cirrhosis of liver or various liver related complications. So what are these patients? These patients are patients who are having steatohepatitis and MASLD score or MAS score of 4, more than 4, or fibrosis, that is F2 or more than F2. So this is the group of patient of MASLD having fibrosis 2 or more than 2 and MAS score of more than 4, where we want to focus upon. Initially, the way of defining these risk profile was based on biopsy. Now we are shifting towards the non-invasive test. And then second one is what we want to know is the clinically significant, MASH. So any MASH who is having fibrosis greater than either or greater than 2 should be followed up closely, because these are the patients who are going to progress and may end up in cirrhosis or various other complications. Now, just a few words about the prevalence. As I just said, the burden is humongous. Almost 35% of the population actually have NAFLD. Out of them, almost, and the pediatric population also prevalence can go up to 15%. 7% has MASH. Total population of the world, 7% of them have MASH, and ultimately 1.5 to 1.8% actually land up with cirrhosis. But these figures are much more worrisome in diabetic patients. You can say almost 70% actually have MAFLD, almost 35% have actually MASH. 20% of the whole diabetic population actually are MASH at risk, means those patients are at risk of developing various liver related complications and malignancy. So this is a very big number. And 7% of them are actually going to end up with cirrhosis of liver, which we used to diagnose till now, the cryptogenic cirrhosis. So this is a very, very huge number, and this raises a question. In the last 50 years, we were talking about microvascular complications, macrovascular complications, neuropathy, nephropathy, retinopathy, or cardiovascular disorders, but liver was not there. But if you compare the prevalence of those complications, it's actually same, 20%, 25% on an average. And the whole care of diabetes was centric to prevent those complications, and we were never... the liver was just an ignored entity, and now we are realizing what we were actually missing. So, and even that, for that matter, even the pre-diabetics also have a very high figures of MASLD prevalence, MASH, and then chances to get converted into cirrhosis and all. So, because of this, this recent, enlightenment which has happened to the diabetic community, there has been consensus statement published by ADA in May 2025 that now we can no longer ignore the liver. Liver has to be the part of the cardiometabolic care. Recently we had a term CKM, that is cardiac kidney metabolic syndrome. Now probably we are going to have cardiac kidney liver metabolic syndrome. So that's the thing. So till now we were ignoring the liver, but now we need to monitor it, screen for it, monitor for it, and then ultimately, if required, intervene at appropriate time so that we can prevent this progression of MASH into cirrhosis. That is what we do for any other microvascular and macrovascular complications. So again, the relationship between the diabetes and MASLD is bidirectional. The presence of diabetes in MASLD increases the not only the prevalence, the rate of progression, and the chances of developing malignancy. At the same time, if MASLD is present in diabetes, MASLD presents itself as an independent predictor of various non-liver related events, cardiovascular event, non-liver related malignancies, and so on. So they impact each other's course. Traditional way of diagnosing MASH was the biopsy, but biopsy used to be, one thing, it's painful, it's expensive, it requires expertise, and then when we talk about the prevalence of 70% of diabetes, we cannot go and subject everybody to biopsy. So we have to, though it is a gold standard, and then there are certain issues in terms of reliability of the test from where you have picked up the sample, because sample is just a very, very minute fraction of the liver. We may skip the pathological part and the biopsy may be actually misleading. So because of these challenges, non-invasive tests are now coming more in force. And this is just the way, this is just the way the classification of fibrosis is being done. And this is just to say that if you diagnose fibrosis in the liver, how rapidly it is going to progress. Because at the end of the day, patient wants to know how rapidly it is going to get me into the problem. So whenever someone is having only steatosis, the progression rate is over 15 to 20 years for one stage progression. It's F0, F1, F2, F3 and F4. Once we have a steatohepatitis, then the average progression of one stage is by 7 years. In fact, if you see more closely, as you go more advanced stages, the progression happens fast. Like from F0 to F1, it is around 7 years. From F1 to F2, it is around 5 years. From F3 to F4, it is around 3 years. So more closer you go towards the advanced degree of cirrhosis, the rapid is going to be the progression. So, and of course there are certain risk factors, diabetes, obesity, older age comes into this, which can lead to fast progression. This is the classification. F0 is normal, F1 is perisinusoidal fibrosis, F2 is portal fibrosis, F3 is bridging fibrosis from central to center, from or center to portal regions, and F4 is the clear classical cirrhosis we are talking about. So it is like as the degree of fibrosis increases, the stiffness of the liver increases, and that is what we use in one of our key non-invasive tests. So ultimately what we realized, it is not just the presence of fat into the liver that is going to be the marker of on further event and progression. It is the presence of fibrosis which will decide ultimately the outcome. So whenever we talk about screening of diabetes for MASLD, we actually find out those people who are having fibrosis in their liver, not just the hepatitis or just the liver deposits. And since the prevalence is almost 70%, so in diabetes and obesity people, actually we can skip, generally what we do ultrasound, we found out it's a fatty liver, and then we subject those fatty liver patients to the fibrosis screening. But in diabetes, we can skip that first stage and directly go for fibrosis assessment, because we know that most of them are actually ultimately going to have the steatosis. So these are multiple tools that are available for steatosis. We have fatty liver index, hepatic steatosis index, steato test, and these are blood-based tests. And then we have ultrasound and the cap estimation by transient elastography that can assess and tell us about the amount of steatosis in the liver. And then the important thing is about fibrosis. Initially, the only way used to be the biopsy, but now we have both blood-based test and the imaging-based test that can tell us about the surrogate, the presence of fibrosis. Blood-based tests are FIB-4 test or EPRI score or NAFLD fibrosis score. Some of them are generally available tests, like FIB-4 is based on very simple parameters which are there always with our diabetic patients. Some are proprietary tests like ELF score, and then some and then imaging-based score. The most common one is the vibration-controlled transient elastography, what we call as FibroScan. Then we have MR elastography, the liver multiscan, and then there are composite score based on the imaging as well as the blood-based markers, just to improve the specificity of the test compared to the imaging only. So these various calculators are available online. Based on that, we can calculate these FIB-4 scores or NAFLD risk score. So, and they are generally being, they generally require age, sex, SGOT, SGPT, platelet counts, and so on. So, generally these markers are anyway there with the patient. So, based on that, we can decide what is the risk. So, this is just, and the second most commonly used non-invasive test is for fibrosis is the FibroScan. We have 3 versions of models available by, ever since. This is one is the 430, which is generally available in most of the setup. Second one is 530, and the advanced one is 630. So this is mini, this is compact, and this is total solution. That is what they say, or the claim. And this 630 is advanced version because it not only measures the liver stiffness, but it also measures the spleen stiffness. So not only will tell about the degree of fibrosis, but also by measuring the spleen stiffness, we can measure the degree of portal hypertension. We don't need to do the endoscopy and see the varices are there or not. And once we are treating them, what is happening to the varices, we can just see the splenic stiffness. If it is going down, it means your portal pressure is also going down. So that these are the various models available. Then important thing is the probes. That they will have 3 kind of probe. Most common one is medium probe, then M probe, that is what we called as, and then in obese patient we require XL probe, and sometimes in children we require S probe. Selection of probe is very, very important, because if do not take the proper probe selection, then the readings may be misleading. It may overestimate the fibrosis and especially can give us the wrong staging of the patients. So, and the preparation, what we need to do, the fasting, it is required 3 hours, because once you take the meal, actually portal circulation increases and the flow to the liver increases, which makes the liver more stiff and you will get falsely high level. So fasting is required. No alcohol, of course, loose fitting clothes so that you can access the right area. The important thing is the FibroScan actually evaluate a much larger area of 3 cubic centimeter, which is 100 times larger than what we see in microscope with biopsy. So chances of missing or mislabeling the staging is lesser with this non-invasive test compared to the biopsy. And what it tells us, this FibroScan gives us a degree of fibrosis. It tells us about the degree of steatosis by value of CAP, and by using this newer version, we can actually monitor the portal hypertension also by measuring this. And so correct probe selection is essential. There is increased failure in the presence of obesity and presence of ascites, and so that every machine have automated probe selection tool which will tell us that which probes is correct for the patient. So if someone is obese and we are using M probe, and if this tool will directly detect the skin to capsular distance, that is SCD, skin capsular distance. If that distance is less than 25 mm, then we can use M probe. If the less distance is more than 25, then we have to use the XL probe. So that is important to get the accurate reading and having high specificity to label someone as advanced fibrosis or not. So these are the various parameters which are there with these S probe, M probe, and XL probes. I'll not go into detail. The important thing is less than 25 and more than 25, based on which we are going to decide. And this tool directly tell us that what is going to be required. So it will tell us if whether we require M probe or XL probe automatically in any particular patients. So basically what it's a high negative predictive value test, which tells us that if the LSM, that is liver stiffness measurement, is less than 7, then there is no significant fibrosis. The positive predictive values may not be that high, it may be around 60 to 70%, but what we want is we want to rule out those people who have fibrosis. And then of course, there is depending on the degree of LSM value it gives, we can correlate with the severity of the fibrosis also. So it helps in prognostications also, not only in diagnosis but also in prognostication. And at the same time, it is now being used to assess the response to the therapy or response to the intervention. If there is a change in LSM value of more than 30% increase, then it means that the situation is deteriorating. If there is a decrease in LSM by 30%, then it means your treatment is working. So it's used for diagnosis, it's used for prognostication, and it is used for monitoring of the treatment response for all these 3. We don't require biopsy now to see the impact of the treatment. We just have a word of caution. These are certain situations which can give you falsely high value. Someone who is having very high SGOT, SGPT values, or active hepatitis is going on, cholestasis is going on, congestive hepatitis, all these things makes liver hard, more stiff. So of course we are going to get more LSM. So we need to correct those tests. In diabetic patients, especially when we have a CKD, it's a fluid overloaded state. Again, the liver measurement by LSM measurement by this machine can actually give a falsely high value. So these are certain precautions which we need to take. Again, so this is the way, the last, I think, first two we have already discussed. Third one is ELF, which is blood-based test, which includes three components. One is TIMP, that is tissue inhibitor of metalloproteinase. That is second one is propeptide of type 3 procollagen, and then first one is hyaluronic acid. So based on, this is all blood-based test. It's a proprietary test available with one company, but it is a non-invasive blood-based test. So anyone who is having ELF score of more than 9.8, that they have advanced fibrosis of F3 or F4, and if it is more than 11, then it is it's a cirrhosis. So the few words that if we are going to subject everybody to FIB-4 score, then we need to know that almost 40% are going to land up with cutoff of more than 1.3. That is the cutoff which has been selected for the purpose of high sensitivity cutoff, and high negative predictive value. So almost 92% of individuals who have a FIB-4 score of less than 1.3 are not going to have significant fibrosis. However, when we take cutoff of more than 2.67, it is a high specificity cutoff with high positive predictive value. So something in between 1.3 to 2.67 is indeterminate category. So less than 1.3, low risk. Just wait and watch, do lifestyle intervention. More than 2.67, then we need to follow them carefully, maybe refer to the hepatologist. 1.3 to 2.67 again is intermediate risk, where we need to do additional tests. Now we need to be careful with these cutoffs, like in old age, because one of the factor in calculation of FIB-4 is age. So is this parameter is valid for between the age of 35 to 65. When the age is more than 65, the cutoff is 2. Otherwise, we will end up overestimating the FIB-4 and refer more patients for further evaluation, which will create a burden. Then again, in Indian setup, sometimes we say that India develops the MASLD or other complications, cardiac complications much earlier, so age is lesser for them. So the cutoff for Indian population suggested by some studies actually 1. And on the other side, some suggest actually 1.5, saying that we need more higher specific cutoffs because we are resource limited settings. We cannot screen anybody and everybody who is more than 1.3. Fibros can cost 5,000. So again, some studies have shown up, used the higher cutoffs of 1.5. So this is how we do it to decrease the number of indeterminate patients. We need to take 2 tests in sequence. First we do FIB-4 and then we do fibroscan, and then ultimately based on these 2, if we find the presence of advanced fibrosis, then we treat them, monitor them, and if we find that they belong to low risk, then they are going to be just followed up. So this is how the that is a tier 1 staging of the staging protocol or screening protocol, where we do FIB-4, and then this is tier 2, where whoever is having 1.3 to 2.67 of FIB-4 is subjected to second line test, that is fibroscan, and then based on that value, these either being referred for just a follow-up or being referred to hepatology for further imaging and further management. If someone who is having directly more than 2.67, then they are high risk for fibrosis, so they are being directly referred for further interventions. So just it's a busy slide. Just want to highlight that fibroscan values actually can give you proper risk stratification also. Like more than 8 is significant fibrosis, more than 10 is advanced fibrosis, more than 15 is actually cirrhosis, more than 20 with platelet count less than 1.1 lakhs, or more than 25 with or without any kind of platelet counts actually indicates decompensated liver disease. So you can quantify the severity of the disease also just based on the fibroscan value without doing the biopsy or not. So once we have staged the disease, now screen the disease, stage the disease, we need to talk about the treatment. The treatment starts with, of course, with lifestyle intervention, weight management, and we know that we require at least 5% weight loss to reverse the steatosis, 7% around to reverse the steatohepatitis, and more than 10% to reverse the fibrosis. So that's one thing. And then we require exercise, at least 150 to 300 minutes of moderate intensity, or 175 to 150 of vigorous intensity exercise every week to reverse these pathologies. There are multiple drugs which are now emerging. Some are already existing, some are coming, which are targeting these pathways, insulin resistance, fat toxicities, then there inflammation, that is FGF19 and FGF21 pathways, and then they are also targeting the beta oxidation of liver fatty acids pathway. So multiple drugs are coming. These are the currently available drugs for diabetes management who has potential role in MASLD. So we have pioglitazone, which improves steatosis and steatohepatitis. Fibrosis reversal is plus minus. Evidence is not that strong. Then we have GLP-1 receptor, and then we have GLP-1 receptor, and now we have GLP and GIP dual analogs, which improves steatosis, steatohepatitis, and fibrosis, everything. SGLT2 only reverses the steatosis. It has not been shown to affect the reversal of fibrosis. So these are the things which we need to know. These are the already completed trial, regenerate trial, which is with obeticholic acid. Reversal was seen with fibrosis, but the problem was pruritus and jaundice in almost 50% of the patient. Pruritus and dyslipidemia in almost 50% of the patients. That's why the trial was prematurely terminated. And then we have resmetirom, the MASTRO-NASH trial, which we just recently published in 2024. And then the interim analysis of STENS study with semaglutide published recently, again in 2020, I think late 2024, which again showed significant reversal. We have these newer drugs, which trials are already ongoing, Enlighten, Synchrony, and Native 3 trial. These are pan-PAR receptor agonist, or the pathways which are directing towards FGF23 molecules. So these trials are ongoing, and probably and the interim analysis is showing promising results. Just to highlight the SENSE 3 trial, which is again showing significant reversal in steatohepatitis as well as in the liver fibrosis, significant compared to placebo. Then we have and in that was based on the biopsy. Even the non-invasive markers are also showing significant betterment. Then we talk about the tirzepatide, which is Mounjaro, then again it have shown in Synergy NASH trial of significant reversal in MASH as well as significant reversal in fibrosis. Then we talk about triple agonist, then survodutide, and again it have shown better result than placebo. Then we have resmetirom, that is the MASTRO-NASH trial, which is the recently approved drugs, non-anti-diabetic only drug available or approved by FDA for treatment of MASH per se, with or without diabetes. For F3, F4 stage, again showed reversal of steatohepatitis as well as reversal of fibrosis. So, and then bariatric surgery, especially in class 2 and class 3 obesity, also shows significant reversal of NAFLD whenever required over and above the pharmacological therapy. First time in 2025, now the liver has also been integrated into the care of diabetes. Now presence, just like the presence and absence of ASCVD, heart failure, CKD was a determining factor to select the drug of choice for diabetes management. Now we have MASLD also in the same line. If the MASLD is present, especially MASH at risk is present, then we need to select our drugs, anti-diabetic drugs, based on those things. And these drugs are same GLP, GIP analogs or GLP analogs or pioglitazone, at least as of now. Now, not only this screening and staging, not only screening tells us about the presence of MASLD, it would also tell us about the staging of the disease, and based on which we can again select our anti-diabetic agent. So for anti-diabetics, when it comes, it's a GLP, GIP option that is available. However, for MASH, if there is a residual risk even after use of GLP, GIP analogs or GLP analogs, then we can have resmetirom, which we can use for F3, F4 to cut down the residual risk that is there after GLP or GLP, GIP analogs in a diabetic patients. If the fibrosis reversal is still not happening, we can club them with GLP or GLP, GIP. However, right now we do not have a data on the combination use, but potential role of combination has been suggested. Basically meant for F2, F3 stage. Based on the non-invasive marker, we don't need biopsy. If biopsy is there, it is fine. So F2, F3 is the people where we want to go for treatment with resmetirom. And then ultimately we assess the response at 12 months. If there is no response, then we stop it. If again, as I just said, that if the LSM value decreases by almost 25 to 30%, that it indicates the response, you continue. If it is not there, then you have to redecide or see what is going wrong. Maybe lifestyle is not better. Maybe we want to add GLP, GIP, or maybe we want to stop it. Maybe the drug is not working at all. So, and just the two slides, just beyond the diabetes, we have multiple other hormones which affects the MASLD, that is, sex hormones, thyroid hormones, GH hormones. So all these disorders, growth hormone deficiency, hypothyroidism, hypercortisolism, hypogonadism also needs to be ruled out in a diabetic patients. If the MASLD management is failing in a diabetic patient, sometimes these patients can have underlying disorder which needs to be corrected if we want to have a good response. So coming just to HCC screening, the important thing which I want to highlight is that in diabetic with MASH, we can develop HCC even without the development of cirrhosis. In fact, 1/3 of liver cancer that is going to happen in diabetes will have without the background of cirrhosis of liver. So whenever there is a cirrhosis, of course, you do the routine screening for what is recommended for cirrhosis patients. But even if the cirrhosis is not there, based on the risk factors like presence of diabetes or obesity or HCC or older age or there's alcohol intake, we have to monitor them for liver cancer also, maybe by way of just doing the USG or just monitoring the alpha fetoprotein. So that's another way. So just to summarize, so MASLD is prevalent, it is progressive, but at the same time, if screened and diagnosed in time, it's preventable. So screen, stage and select the drug based on the drug stratification. That should be the motto of the full treatment. And this is high time where we integrate the MASLD care in our diabetes care to improve the liver related outcome, because it's equally prevalent and equally important as our other micro and macrovascular complications. So the whole purpose is to, because since it can be prevented from progression, so the purpose is to intercept it before it progresses into full-blown cirrhosis of liver. Thank you very much. With this, I'll end, and if there are any questions, I'll answer.
Thank you, Dr. Kasliwal, for your practical approach in addressing liver health and diabetics. This will surely help clinicians spot red flags earlier. The dais is now open for discussion.
Thank you, sir, for the extensive presentation. We all know that MASLD basically is seen in obesity. Do the lean people also have any risk in having MASLD?
Yeah, so almost the total MASLD cohort we are talking about, almost 20% of them are lean people. But again, that definition is very soft, because how do we define lean? Like Indians who have a central obesity, if we just use BMI criteria, we may miss them. So, but still proper lean patient, the prevalence is the whole cohort, out of them 80% will be obese, 20% will be lean. And in fact, but in those lean also the target weight loss is around 5% if you want to reverse it.
Any question from the audience?
In the Indian guidelines, surrogates are included. And
yeah, I knew this question is going to come up. So yes, saroglitazar is included, but it is not FDA approved. So we generally have those guidelines because it's not approved by them. So we don't, see this word there. As far as saroglitazar is concerned, the problem is that the studies are mostly small, mostly company sponsored, mostly they shown reversal in steatosis, to some degree in steatohepatitis. The strong data on fibrosis reversal is not there with saroglitazar. So that is the problem. If it is available and we just want to use it, but the strong data, especially in terms of histopathology or long duration dependent, long improvement in, sustained improvement in non-invasive marker, that is not available. So data is there, but scanty and scarce. It's hard to make a strong recommendation for a lifelong therapy, because it's going to be lifelong therapy. So that is another challenge. Is what we have seen till now is ultimately improvement in histopathology, improvement in marker. We need to see ultimately actually it improves the end point, what we see with CVOT outcome, whether ultimately it is going to stop the cirrhosis. Ultimately, how many % of patients did not have cirrhosis because of that? How many did not have HCC? Ultimately, the length or the duration, the life span is actually increased. So hard endpoint data is still going to come. What we have just data based on the improvement in the markers, which we need to see. And that is very important, because we know the dropout rate for GLP, GIP is actually 60% at 1 year, 50% at 1 year. That is the, again, US data. In our case, so it's maybe going to be worse only, and 50% at 2 years. To sustain them, to take them for 5 year, 10 year, 20 year, we need to see whether that the benefit is going to be sustained or not.
This pioglitazone, whatever pioglitazone say, it will also cause weight gain due to fluid retention. So the amount of the challenge of weight loss may be compensated by this pioglitazone.
So yes, so there is weight gain, of course, that happens. There is some degree of water retention is also happen, but not everyone does it. The benefits outweighs, I think, that small concern that is there with that is going to be always there with pios, but because of that, probably it is underutilized also. It reverses the steatosis, steatohepatitis, and to some degree fibrosis. But the problem is that no one is going to do a big trial with pioglitazone, especially no pharma company. So we'll never come to know. But I think for Indian setting, at least this is what we can offer. We cannot not offer the GLP, GIP to everyone. But pios in judicious, of course, in a customized based decision, depending on the patient profile, can be used for the treatment of MASH. This is what the best we have in those limited settings like India. Thank you.
So in your practice, what is the pharmacotherapy that you use? How do you approach? In your practice?
In MASLD.
No, yes.
So that's what so it's the same. Of course, the glycemic control. Then, of course, we try to incorporate the drugs which have an impact on MASLD. Patients' pocket actually decides, so pioglitazone becomes part of it if we cannot do anything else, and if patients can afford, of course, then especially F3, F4 fibrosis, where we will try to push for GLP analogs, and nowadays we have GLP, GIP analogs. So that is one thing we can do. Saroglitazole, somewhere in between. So F2 tak, it's fine, but F3, F4, if possible, we want to go for a proven therapy like GLP, GIP analogs. If it is not, then in fact we can give pioglitazone plus saroglitazole. Then we can actually, only someone is having CAP which is more than 285 steatosis there, then SGLT2 inhibitor can be tried. So, but fibrosis reversal is not there with SGLT2. At least in the studies, it's not there.